So thank you. Thanks so much to the organizer for the kind invitation. It's great to be here. My topic today is genome-based disease prediction and prevention, and I will talk to you about an ongoing study of ours where we have tested the impact of returning genome-based disease risk information directly to study participants. But first, in order to give you a little bit of a context for the study, I will say a few words about genomic research in Finland. Now, as you probably all know, Finland is a small country located in the northern parts of Europe. Sweden is our neighbor in the west, and Russia our neighbor in the east. The population is small, only 5.5 million. And similarly, as in other Nordic countries, healthcare is mostly public. And what we also do is monitor healthcare use systematically nationwide. Now, for somebody who is interested in personalized genomics research, Finland has certain opportunities and advantage to offer. And this is something that is well recognized within Finland, not only by the universities, but also by policymakers and the population. So there is a strong willingness among Finns to participate in medical studies. Everyone has access to healthcare, and we have nationwide health registers that span the past 50 years to which everyone can be linked through a unique identifier. So this means that the health registers can be used for comprehensive and longitudinal research of health and disease. And in addition, we have a nationwide network of biobanks, which makes it easy for individuals to participate and donate samples to research. And in addition to this, for quite some time now, we have had a strong effort into characterizing the genome variation of the population. And I'm going to show you one example of this, the FINGEN study, in which 10% of the population will participate. The genome information or the variation will be determined for everyone, and this will be then combined with the digital healthcare data to provide a platform for medical innovation. This is a public-private partnership with wide and open cooperation. We have universities, hospitals, hospital biobanks, and pharmaceutical companies participating here. And I wanted to point out that the study participants here are recruited through hospital biobanks, and this means that this is not going to be a collection of super healthy individuals. Rather, we will have patients participating with a wide variety of disease, so the FINGEN will be a very suitable platform for broad medical research. But the topic of my my presentation is a distinct study that we call GeneRISK that we set up already in 2015. And the reason for setting up this study was the progress that had been made in the genetic mapping of common complex disease. And it had been shown that numerous genetic loci impacting the risk for these diseases had been identified, and polygenic risk scores had been shown to significantly predict the risk for many of these diseases. The GeneRISK study focuses on coronary heart disease. And this is the disease where genetic factors explain half of the disease risk variation between individuals, and the polygenic risk factors have a major contribution to the overall risk. Still, the polygenic risk information had not been used in clinical practice, so in order to facilitate the clinical translation of genomic research and to empower individuals to undertake risk-reducing behavior, we set up this study and recruited 7,350 individuals from southern Finland. They were randomly selected. Their risk for coronary heart disease was determined based on traditional risk factors and genomic risk factors, and we tested the impact of returning the disease risk information to everyone using a web-based tool that we had developed in-house. Now, the GeneRISK study is a longitudinal observational study, and the baseline characterization involves a health check, e-questionnaire, and array-based genotyping. Every single participant had been consented for return of disease risk data, biobanking, and recall. But what is really special about this study is the active engagement and communication with the study participants. They truly expect us to be actively in contact with them, and we have. During the past year, we have been conducting the first follow-up study, calling them back for an additional health check a year and a half after baseline. The study participants are ordinary Finnish males and females. As you can see here, they are all between 45 and 65 years of age. They are slightly overweight. They have slightly elevated blood pressure and blood lipids. And based on the information that we collected at baseline, everyone received personal information on their 10-year risk for cardiovascular disease, based on traditional risk factors such as age, sex, smoking, blood lipids, and blood pressure, and a polygenic risk score that we built from 49,000 SNP markers. When the disease risk calculations were ready, we sent the study participants a text message and asked them to log on to the research portal to check out their results. And the way we communicated the results was using the interactive web tool Cardiocompassi that we had developed. And here you can see a screenshot of what the Cardiocompassi result for one study participant looks like. So Cardiocompassi displays the risk in many different ways. It shows the overall personal risk for CVD as an absolute number. According to the Finnish National Guidelines for Disease Prevention, a 10-year risk that exceeds 10% is considered high, and then the recommendation is that that person sees a doctor to discuss how the risk best can be managed. Of note here is that Cardiocompassi computes the overall risk in two different ways. We have the blue arrow showing the risk computed based on traditional risk factors only, and then we have the orange arrow showing the combined risk of the traditional and the genomic risk factors. And if either one of these estimates exceeded 10%, Cardiocompassi will advise the user to see a doctor. In addition, the CHD risk is displayed as a function of age, and it's easy to compare the risk, the personal risk, to the risk distribution in the population as well. And finally, Cardiocompassi has an interactive feature here on the left. This is a way where we offer the user the possibility to try out how changing the values for modifiable risk factors can impact on the overall risk. So for example, here we have a person who is a smoker. By clicking that tab, he can find out what his risk would be if he didn't smoke and all the other risk factors were the same. You see the broken line here. So here you can see the distribution of the cardiovascular disease risk across the whole cohort at baseline. 25% of the study participants had elevated risk. And the yellow slice here shows individuals who were at high risk due to a pre-existing condition, mostly diabetes. Here you have individuals with a risk between 10 and 15%, and this slice here indicates individuals who have a risk exceeding 15%. And if we zoom in to these two groups and ask ourselves, is there room for intervention? The answer is yes. 40% of these people were smokers, only 17% were treated with statins, and 30% of them were obese with a BMI over 30%. Now, as I told you earlier, we have just finished the first follow-up of the study cohort a year and a half after the baseline characterization. We called them back. They participated in a second health checkup, and we probed their attitudes and health behavior with an e-questionnaire. And almost 70%, 7-0, decided to participate in the follow-up study, and this is what they told us. 90% said that they had received disease risk information that was easy to understand and that was useful. Between 20 and 30% thought that the disease risk information was either unexpected or concerning. Of these study participants, almost everyone thought that genetic factors importantly influenced the risk, but at the same time, they also thought that they themselves, through their lifestyle decisions, can impact on their risk. They also said that receiving or knowing their personal risk motivates them to take better care of their health, and an overwhelming majority thought that clinical doctors know how to utilize genome information in their everyday practice. So I get the same response from doctors in Finland as well, I have to say. So obviously, feeling inspired to make a lifestyle change is very different from actually being able to carry one through. So obviously, we were extremely interested in finding out whether our study participant had met their goals. But before I show you those results, I wanted to give you two examples of study participants, just to give you a flavor for how the risk was presented and perceived from an individual perspective. So here is the first case. A 63-year-old male. He had episodes of arrhythmia, sleep apnea, and hypothyreosis in his anamnesis. His father had early onset coronary artery disease, and he had had elevated cholesterol values measured earlier, and he had been receiving dietary advice because of that. At baseline, we could see that his body mass index was around 27 and blood pressure was slightly elevated, and his cholesterol values were very high. They were as high as 8 millimolar, and the LDL cholesterol was also very high, 5.5. His genetic results is displayed, here. 1.1 standard deviations above the mean, and you can see that this then sums up to a very high risk of 19%. So at follow-up, he told us that he thought that the results were easy to understand. He didn't think that these were concerning results. He thought also that genomics and physical activity impacts on the disease risk, but he wasn't sure about the impact of cholesterol. So what did he do? Well, he saw his doctor. The doctor put him on statins and asked him to monitor his blood pressure. And when he came back, his cholesterol levels had dropped significantly to 5.8 millimolar, and his systolic blood pressure had also gone down. And this then, as you can see here with a dotted line, this is how much his risk changed because of the changes in the risk factors. Second example, 40-year-old male this time. He was treated for hypertension. Similarly, as the previous case, he also had a positive family history of early onset coronary artery disease, and also he had this history of having had elevated cholesterol levels measured before, and he had received dietary advice. His body mass index was slightly higher than in the previous case. His blood pressure was also on the higher side, and also in this case, the total cholesterol and LDL cholesterol, they were both very high, 7.8 millimolar and 6 millimolar. And in both of these cases, we excluded familial hypercholesterolemia, so this is not the cause for hypercholesterolemia in neither of these cases. He also had an elevated polygenic risk, here 1.2 standard deviations above the mean, and when we sum all this together, he will land on an overall risk of 12.1%. And in this case, his risk is lower in comparison to the previous example because this is a younger person. When he gets 63, as you can see, his risk will dramatically increase. He said that the results were easy to understand. He didn't think the results were concerning. He didn't think they were important. And he thought that cholesterol and diet has nothing to do with cardiovascular disease risk. Other factors maybe, but cholesterol not. Now, what did he do? He did nothing. He didn't consult his doctor. He didn't change his lifestyle, but he gained weight, 1.2 kilograms. And this is what happens if middle-aged people don't pay attention. They will gain weight. And his cholesterol values went up a bit to 8.2, which is very high. And you can see that these changes impacted on his overall disease risk a bit too. Okay, so back to the whole cohort then. Remember now that 89% had told us that they felt inspired to undertake lifestyle changes because of getting this information about their personal disease risk. So we wanted to look into it, how well they had succeeded. And here you can see the study cohort divided into two groups. In the first column, you see the individuals at high risk, more than 10% risk. And in the second column, you have individuals with low risk. And as you can see, the high-risk individuals had achieved sustained weight loss. 16%, give or take, had achieved this. On average, they had lost 2.6 kilos. Across the cohort, between 14 and 15% of smokers had quit smoking, which is a very high number, considering that the annual cessation rate is around 4% in Finland. 21% of the high-risk individuals had seen a doctor during follow-up. And when we look at all these three things together, we see that 36% of individuals in the high-risk group had taken some action to lower their risk. Now, because we really want these people to do something actively to reduce their risk, we were really interested in finding out what is it that differentiates the 36% who take action from those who remain passive during follow-up. And we also wanted to know whether genetic factors may have something to do with this. So we zoom in on the high-risk category, divide it into two groups. The first column, these are the 36% who took action, and in the second column, you have the remaining in the high-risk group. And as you can see, we have fewer males in this group who were active, who actively tried to lower their risk. But in terms of the other traditional risk factors, age, BMI, cholesterol, and smoking, there were no big differences between the two groups. But when we look at the polygenic risk score, we can see that individuals who took action to lower the risk during follow-up had an increased polygenic load in comparison to the others. Now, there has been an ongoing debate whether knowing about one's genetic risk for disease can motivate changes in health behavior. And there are previously published studies that suggest that disease risk information based on a few SNP variants with weak effects does not motivate change in lifestyle behavior or health behavior. On the other hand, we know that genetic information based on DNA variants with a moderate or a strong effect on the disease risk often can prompt health behaviors such as screening or medication or surgery even. In our study, we took a bit of a different approach when we chose to combine both traditional and genetic factors when we did the disease risk estimate. And we also used a polygenic risk score, which has an impact on the disease risk that is equal to the combined effect of all the traditional risk factors that we used in the model. And what we saw was that the participants said that the personal disease risk information given to them in this fashion motivates them to improve their lifestyle. Individuals at high risk more often took action to lower the risk than others. And finally, action to lower the risk associates with an increased polygenic load. So taken together, our data suggest that combining or integrating genomic and traditional risk factors for common chronic disease prevention and communicating this information back to the individual can support changes in health behavior, particularly when the genomic risk is elevated. Now, what are the lessons learned? Where do we go from here? From our perspective, integration is a key. The information about the genomic risk for a number of complex disorders is constantly getting more advanced. And in order to accurately predict and prevent disease, it's important to combine or integrate the genomic information with clinical data whenever that is possible. Also, in order to make sure that the genomic information is accessible to all patients, it is important that we integrate the genomics tools into the IT systems that is being used by preventive healthcare. And also, it would be helpful if genomics would be part of the national guidelines for disease prevention, which they currently are not. In Finland, we are pushing these things forward, and we have currently ongoing pilot studies where we have integrated the Cardiocompass tool in the IT systems of primary healthcare, and we have studies ongoing both in Finland and in Estonia. And we are looking forward to getting the first results from these studies later on this year. Finally, I want to acknowledge, all the GeneRISK team at our institute and our many GeneRISK collaborators. In particular, I want to highlight here Professor Samuli Ripatti, who is the co-PI of the GeneRISK study, and Johanna Aro, who is the coordinator of the GeneRISK study, which obviously is the most important of them all. Thank you so much.